This is video history from the J. Bay Jacobs Library for the History of Obstetrics and Gynecology in America. My guest this morning, Dr. J. Robert Willson, President of the college in 1970 and 71. It's a sunny April morning in the year 1987 in Las Vegas, Nevada, when we have a chance at long last to talk to Dr. Willson. And Bob, let me begin by asking you, because it certainly has been a long and distinguished career, where did you start and what have you done over these years?
I started at the University of Michigan, Warren, where I was graduated from medical school in 1937. It's in the midst of the Depression. I didn't have money enough to get out of town, and I didn't want to go anyway, so I stayed on there as a resident. And then was on the faculty at the University of Chicago, and went to Temple University as chairman of the department. And
what year was that?
That was 1947. And was there until 1964 when I came back to Michigan. And I remained there until 1983. And I'm now in Albuquerque, where I'm working part-time in the department at the university.
So you were chairman at Temple University for 17 years and then at the University of Michigan for, I guess, 18.
No,
19.
No, it was less than that because I resigned as chairman in 1978. So I just stayed on as in the department.
And what are you doing these days in Albuquerque?
I'm working part-time in the university. I work 4 days a week, and we're having great fun with long weekends exploring the area and traveling and enjoying life, particularly since I'm doing things I like to do rather than things I have to do.
Well, there are lots of things we could talk about in terms of your career, but in harking back to the time you were president in 1970, I think there's a widespread and pretty nearly correct perception that you were the first, at least among the very first individuals who brought to the college a concern for the social side of medicine and the needs and wants of women in addition to just the science and education of obstetrics. What were your feelings in 1970 on the social issues? What brought you to that point?
Well, I was concerned about a number of things. As you know, the number of obstetrician gynecologists we were producing and their jobs, what sorts of services they were providing for women. I was interested in midwifery, and it all added up to the idea that perhaps we could be doing a better job than we were doing with 100% operative obstetrics and operative gynecology and not paying much attention to the rest of the life of women.
And you set forth some various proposals at that time. Perhaps we could talk a little bit about some of those. That is in terms of the role of midwives, the numbers of obstetricians we ought to be training. Could you tell me about that?
Well, I still believe that we should have alternatives of care for women. That, as you well know, and particularly was brought out in your recent survey, that much of the professional job of the obstetrician gynecologist now is ambulatory care, rather than the traditional role of consultant surgeon as it was many years ago. I believe that if we do expand the role of midwives and nurse practitioners and bring them into our practices, bring them into hospital services, that we can provide more satisfying care for women and probably can make better jobs for ourselves.
What is your perception of what's happened with these ideas over the 17 years? Perhaps slow growth.
Well, it's been very slow growth. They obviously haven't been ignored. I've been castigated from all sides for these ideas. As you know, very few women in the country seek care from midwives, and I think the growth of midwifery, however, has been slowed considerably by the fact that we have not really been willing to accept them as professionals.
Perhaps more important than those issues, the alternative care issues, which, at least perhaps we've seen some changes in hospitals in those times, if not changes in people. But you really had a concern, I think, for the needs of women as opposed to the needs of the obstetrician.
I think the obstetrician was taking care of his needs pretty well. And women needed a sponsor and a spokesperson. And of course, I'd been well brought up by Elsie Carrington, with whom I practiced for many years in Philadelphia. And so I was probably more aware of some of the problems that were going on than people who were in all-male practices and had no one to keep them straight.
Have we made headway in those areas? I guess everybody would say we have, but have we done well enough?
No, we haven't done well enough, obviously, but I think there's been tremendous headway. Hospital obstetric services have changed, and doctors have changed. I think we're all much more aware of the problems that are being expressed by women and have been expressed for a number of years. We change with difficulty, but I think we do.
Bob, let me ask you about your at least 2 textbooks. I expected you to be modest about your own career, and indeed you certainly were. You had for a long time perhaps the only book which related to an atlas of operative operations or techniques, which you might mention a little bit. But then I wonder if you'd comment about the influences of your textbook on changing attitudes in practice as well.
Well, I don't know about that. The only thing I do know is it changed a number of attitudes at the University of Michigan. You remember that back in the terrible 60s, I think it was, that there was a big ceremony in the middle of the campus in which my book was one of several that was burned because it didn't actually respond to what this group of people thought they needed.
But then the book changed?
The book changed, but not a whole lot. I think the major culprit in the book was Chapter 4 on the psychology of women, and we changed that.
What were the issues in that, or ought we to bring that up?
Oh, it was a little Freudian, and probably should have been changed before.
One thing that's obviously changed is time itself. You became a departmental chairman in 1947. When, like all of us in 1947, you must have been pretty young. How old were you?
I was born in 1912, so I must have been 35.
You were a young departmental chairman.
And naive. But I learned.
What are the differences between being a departmental chairman in 1947 and the year, let's say, 1977?
Well, it used to be fun. A departmental chairman, although he was not a monarch, could make changes in the department, could do things and get them done within the department rather than having to depend upon tier after tier after tier of committees to approve decisions. When I started as a chairman, there were many students who were just coming back from the service. They were avid to learn and were, quite different from today's students who want to be taught. They don't want to learn. So it's been there have been tremendous improvements, but there also have been I think deterioration in the medical schools, in that With the changing in financing, there is much more concern and need for practice income from the faculty, which makes it much more difficult to do research and more difficult to meet with students and house officers in the teaching program. It's essential if we're going to survive, but it's different.
It's probably fair to ask you, since you mentioned financing of medical schools and enough time has passed, what salary did Temple University pay you to be a departmental chairman in 1947?
Well, I left the University of Chicago. If I remember, my salary was $3,500 a year. They offered to increase it to $5,000 if I stayed, but the lure of being a departmental chairman and the salary of $15,000 a year was more than I could contend with.
Were you expected to do private practice in those years or not?
Yes, I was permitted practice, and I always have done some practice. I think it's important that clinical faculty people do some practice. But I didn't have to earn my way, and I didn't have to practice to pay for the department.
And were there any other full-time people besides yourself?
When I first went there were none. But I recruited several. Elsie Carrington stayed on, and 2 or 3 other people who were finishing the residency and stayed on.
How was it possible in those days to run an obviously very competent and productive teaching department with 2 or 3 full-time people, and today it takes 25?
We didn't have to go to committee meetings, for one thing. There were very few responsibilities outside of the department, and we had close communication with the residents and with the students and with each other, so that I was really able to. I had a lot of time to devote to this, which gradually was eroded over the years by outside things.
Maybe we could wind this up by letting me ask you about one clinical issue, that of cesarean section. Be kind of curious, particularly since cesarean section was something that was well described in your atlas. How often was this done in 1947, and what's your perception of the immense change that's occurred, and is it for the better or for the worse?
Well, if I remember correctly, the cesarean section incidence in 1947 was somewhere around 3 or 4 or 5%. And as a matter of fact, Bill Mangert chided Diekman for a cesarean section rate in the early 40s of 5%. At the University of Chicago, and Dr. Diekman's response was, "I know we do a few unnecessary cesarean sections, but I think we can account for all of them." As you know now, it has skyrocketed. I think my main concern is that people are not learning to do forceps deliveries, are not learning to do some of the things that were pretty routine. I'm certainly not recommending going back to the traumatic mid-forceps rotations and breech extractions and versions and that sort of thing, which really were terrible. But there are many people now who are delivered by cesarean section who don't need to be, because in spite of some of our colleagues, mid-forceps delivery, if someone knows how to do them, and if the patient is selected properly, is not a traumatic delivery. And the same thing is true of some of the other things that we do. Management of dysfunctional labor, for example. People don't do it properly anymore. They give a little oxytocin, and if it doesn't work, they go to cesarean section. So I think I don't know what the rate should be, but I would guess somewhere between 12 and 15% would be a logical one.
Sounds to me like wise advice. Looking back a few years myself, it seems to me you've got the right perspective.
I think so.
Our guest this morning has been Dr. J. Robert Willson. We could, I guess, describe Bob, many people, as senior statesman, but if a statesman means that what you did in the past has to have changed things for the better, then I guess you really qualify. Thank you for being with us.